People don't sometimes realise what a consultant nurse does. And it's a very specific role in the UK, irrespective of what condition you are a consultant nurse in. And it's 50% clinical, which is kind of expert clinical, and it's 50% research stroke educational.
Fellow Homo sapiens, epilepsy research can play a key part, like up to 50% of the role of an epilepsy consultant nurse. In episode 2 with Phil Tittensor, he shares with us some of his research projects covering risk communication, climate change, and artificial intelligence, or AI. He also tells us about his personal background and how that actually led him to specialise in helping improve the lives of people affected by the epilepsies. And also remember, if you haven't watched or listened to it yet, check out the first episode with Phil, released last week, where we spoke of the composition of the role of somebody just named an epilepsy specialist nurse, because they often do a whole lot more than their title might imply.
My name's Phil Tittensor. I'm consultant nurse for epilepsies up in Wolverhampton. I'm also a lecturer for the University of Wolverhampton, and I'm chair of the Epilepsy Nurses Association for my sins.
And what got you into the epilepsies, actually? I didn't ask you that before, and I wish I had.
Mainly there was a personal reason and a professional reason. So the professional reason is I'm a learning disability nurse by background, and people with learning disability or intellectual disabilities, we should be saying now, have a higher incidence of epilepsy, and a higher incidence of epilepsy that's tricky to control. So as an epilepsy nurse, quite difficult to avoid that. Although I only look 21, Torie, I am old enough to have trained in one of the old NHS learning disability hospitals. So lots and lots of people there with really nasty seizures, difficult to control, and often not made any easier by concomitant medication. The personal side was someone that I was very close to. We lived together for some time. Had epilepsy, so there's kind of this personal helping kind of side of it as well. So it was the two things together.
Oh, it's well, I was going to say it's good, it's not good, but it's kind of, I suppose, in a selfish way, nice to hear that you have that personal insight as well, which I no doubt complements your role as what you're doing today, because you see things from a personal angle too.
I think you do, and I think for me as well, there's a small group of people that would have been in a similar position to my partner at the time, who have very infrequent seizures. There's a term called oligoepilepsy, which just simply means seizures less frequently than once every 6 months. And I think those people can tend to get a bit sidelined, your seizure control's pretty good actually, 1 in the last year, that's not bad. But I tell you what, it's just enough to make a massive impact on somebody's life, not being able to drive for one. So that's kind of always stuck in my mind, that somebody who's having 1 seizure a year is as deserving of attention and trying to improve the treatment as somebody who's having 1 seizure a day.
And not solely treatment, but quality of life as a whole, I think. Because again, it's not solely about seizures, but what's the impact of those anti-seizure medications?
Yes, absolutely.
What about the frequent comorbidities that often come along, whether it's genetic, whether it's social, whatever? It's not solely about the seizures.
No, and maybe it's truer to say we keep saying treatment, don't we? We probably ought to say management, or maybe there's another term, but it really means that seeing the person in the whole, seeing them in the round.
Phil, please tell us about the epilepsy research that you've been involved in, and also work with PPI, or public patient involvement, because I know a lot of your research involves that too.
I think it's worth just starting to say that people don't sometimes realise what a consultant nurse does. And it's a very specific role in the UK, irrespective of what condition you are a consultant nurse in. And it's 50% clinical, which is kind of expert clinical, and it's 50% research stroke educational. I sometimes prefer to think of it as educational, because you can do things that are really pushing that educational envelope without it strictly being a research project. So in terms of what I do, you mentioned the PSP, which is a huge piece of work coordinated by Epilepsy Research UK, which should publish in October, which I've been honoured to be invited to sort of represent nursing with, really. And that's kind of trying to set priorities for researchers over the next 10 years or so. So what's important, and this has been an attempt to gather the opinions not just of different professional groups, but also patients, patient groups, charities, really the whole spectrum of people involved in epilepsy and its diagnosis, care, management, treatment, so on and so forth. So it'd be really interesting to see what the top 10 priorities are. I mean, there have literally been thousands, I don't exaggerate this, thousands of questions, research questions that have been submitted. Obviously some are very similar to each other, so it's quite easy to combine those. Others very much stand alone. And the UK is the second country in the world to have done this. So the Canadian PSP published about 12 months or so ago. I believe there's an American one underway as well. It will be fascinating to see whether the priorities that have come out of the Canadian PSP are echoed by our own when the UK one publishes at the International League in Epilepsy British Branch Conference in October. There we go, a plug there for the ILAE. Okay. In terms of personal research, anyone who saw our previous conversation, I mentioned a piece of research on risk communication, which you and I have both been involved with. And really, I think what's struck me with that when we started to analyse some of the data, including cringingly, embarrassingly my own, is that we're not always very good at putting across what risks are and discussing that with people. And I think that's probably because we're not really ever taught as professionals how to go about doing it, what sort of phraseology is useful, whether to go in with open questions, closed questions, no questions, just give the information verbatim. We're not taught about any of this. So actually some recommendations on how you might structure an interview around risk, or a discussion rather around risk, could be incredibly beneficial for patients if we've got an idea how to do it a bit better than we do now, because it isn't as intuitive as you would automatically think. I'm quite involved in intellectual disability research. That's my background. So there's something called the UK Epilepsy and Intellectual Disability Register, which basically is looking at anti-seizure medications and how they may differ when used with people with intellectual disability compared when used with people who don't have intellectual disability, and also the degree of intellectual disability, those with severe and profound disabilities versus those with more mild disabilities. So kind of looking at different ASMs and whether they are more or less effective in terms of seizure control, but also crucially whether they are better or not so well tolerated. So there's some really interesting research there, and that's feeding into some wider European work as well. It's quite exciting. Epilepsy and climate change is something that again we vaguely touched on, Torie, when we last spoke, but there's a large international group called, not very imaginatively, probably Epilepsy and Climate Change, which is kind of looking at the impact of climate, temperature on seizures. We know that people, for example, with Dravet syndrome may be badly affected by particularly sudden changes in temperature, which can induce seizures. We'd like to know whether that applies a bit more widely. There's the flip side of do we as a profession, if you like, contribute to climate change? Can we reduce that? Should we be doing more remote appointments so that we're taking some cars off the road? When we go to conferences, what's the most carbon neutral way of attending? Should we be doing more virtual? If we have to go in person, is it better to take a train than a plane where it's feasible? And all of this kind of stuff. And the other interesting thing, which we were talking about, Torie, just before we came on air, was the effect that sometimes extremes of heat can have even on our medication. So lots of wide-ranging issues around that, which is quite fascinating. So as a consultant nurse, I've got a lot of different projects. I mean, I've just given you a bit of a flavour. There's a couple of really interesting diagnostic ones with artificial intelligence that are also sort of on the agenda. We're partway through one study. We're just submitting a research proposal for another one, which is actually fascinating, looking at normal segments of apparently normal non-contributory EEG, that the human eye, there's nothing there, but could an artificial intelligence actually see some underlying changes that suggest a tendency for seizures? So that's absolutely fascinating.
Thank you so much to Phil for his personal and professional insight into the diversity of work as an epilepsy consultant nurse and the responsibilities epilepsy specialist nurses can hold. To learn more about Phil, make sure that you check him out at torierobinson.com/epilepsy-sparks-insights, where you can find out more about him and links to his work. Also, today we have an announcement. We have some really cool gear / merchandise like t-shirts, mugs, notepads, etc., which you must check out. The link is below under the merch tab on epilepsysparks.com. And also just an example of one of the t-shirts, it says, "Epilepsy does my head in." Now, if you've enjoyed this episode, please share it with your friends, family and colleagues, because it really helps us to get the messages about the epilepsies out to the masses.